Hi everybody. Today we're going to talk about regional interdependence, or RI for short, and expand on that idea. And the basic premise of RI is that everything in your body is connected. Now, if you've ever seen this brain teaser, the idea is to use 4 straight lines to connect these dots without lifting up your pen or pencil. This is to get you thinking outside the box, because the only solution here is to draw your lines outside of the box. And that's the idea behind regional interdependence. Sometimes our evaluations are straightforward, but other times we've got to think outside the box, not only for our injury evaluations, but also for our rehabilitation plans. For example, if this tree trunk represents a shin, I want you to think beyond the shin injury and consider the roots. We can treat shin pain with rest, electric stim, other modalities, and some therapeutic exercises, but if the person has feet like this that go uncorrected, the problem will keep coming back unless we address the roots. Now, while shin pain is an easy example of RI, I want you to keep in mind the true definition is that seemingly unrelated impairments in other remote parts of the body may actually contribute to and be associated with a patient's report of symptoms. Regions of the body do appear to be musculoskeletally linked. Now, here are some other RI examples that we may not commonly think about. There's a positive relationship between low back pain and the presence of knee arthritis. There's a positive association between pes planus and low back pain. And there's also a positive relationship between ankle impairment and low back pain. Hip impairment contributing to knee injuries and knee pain is something that we commonly encounter in athletic training. Another common RI example is greater navicular drop measurements are associated with patellofemoral pain, so remember to consider the roots. In the strange but true category, thoracic spine pain and dysfunction has been associated with lateral elbow pain, and thoracic spine interventions can alter shoulder pain. Now, when it comes to RI, we often first think of musculoskeletal links, and they are the most common. But there are other systems involved that can impact the injury. For example, the biopsychological system means that when a patient has fear avoidance or pain catastrophizing or anxiety and depression, these can significantly affect the injury. There's also somatovisceral examples, and we learn about some of these. For example, left shoulder pain can be a result of a heart disorder or a spleen injury. Right shoulder pain can be from a liver disorder, and low back pain could actually originate from a urogenital disorder. And there are neurophysiological relationships as well when it comes to RI. For example, joint manipulation can affect muscle power. Examples of neurophysiological RI can be found in the literature, especially with spinal manipulation. For example, SI joint manipulation can decrease motor inhibition of the knee extensors, and lumbar spine manipulation has been found to increase gastrocnemius EMG activity. Now, the relationship between patellofemoral pain and the hips has been thoroughly studied. In this systematic review of 21 studies, all of these studies demonstrated that hip exercises decrease patellofemoral pain, particularly if they targeted the hip abductors and external rotators. And here's why. If muscle weakness allows the hips to go into adduction and internal rotation upon foot strike while running, you can see how this places stress on the knee. If we can keep those abductors and external rotators strong, we have better alignment. Of course, if we have all these things happening that go uncorrected while running, it's only natural for an injury to eventually occur. Now, here's an interesting study and a great example of regional interdependence with hip and lumbopelvic region range of motion measurements among college baseball pitchers. This study involving 29 pitchers assessed the following on each pitcher: hip internal and external passive range of motion, hip anteversion and retroversion, gluteus maximus and medius strength, hip internal and external muscle strength, and lumbopelvic control using the Sarman prone active hip rotation test. Here's how the test works. The patient lies prone with the knee flexed at 90 degrees, and the clinician measures active hip internal and external rotation while simultaneously palpating the ASIS and the PSIS for superior and inferior movement. A positive test is when you have excessive or early pelvic or low back rotation with these hip rotation movements, and a negative test would be when hip full range of motion through internal and external rotation occurs without the simultaneous pelvic or trunk movement. Now, the authors found that these pictures did not have any significant strength deficits, but about half of them had poor lumbopelvic control, meaning that the anterior superior iliac spine and the posterior superior iliac spine were moving early or excessively during the hip internal and external rotation movements. A little more than half of the pictures had hip retroversion. This is not something we can necessarily control, but we can improve lumbopelvic stability. So just like this goldfish is misleading us, assessing strength levels can be misleading too. It's important to take a look at the entire athlete, and in this case, lumbopelvic control can be a contributor to an injury. Next, let's take a look at concussions in RI. There are studies that show that sustaining a concussion can increase your risk of a musculoskeletal injury following that concussion. This study involved Division I football, women's basketball, soccer, and lacrosse athletes, where the athletes were followed for 90 days after their concussion returned to play. Lower extremity injuries occurred much more frequently in concussed athletes, about 50% versus 20%. Here's a breakdown of their injuries following the concussion. You can see there are all types of lower extremity injuries here. Here's another study with high school athletes, a very large one, over 18,000 high school athletes across 27 sports, found that concussion increased the odds of sustaining a lower extremity injury by 34%. Here's an RI study that evaluated the relationship between hip motion and low back pain in professional golfers. The authors used the Faber test to measure the distance between the knee and the table to evaluate the extent of hip external rotation in the lead leg or front leg of these golfers. The greater this distance, the less hip external rotation. The authors found that decreased hip external rotation increased the risk of low back pain. They also did a finger to floor distance test to measure general range of motion and found this was not correlated with predicting low back pain. And there was also no correlation between non-lead hip range of motion deficits and having low back pain. Remember, core stability is another example of RI. We always want to try to incorporate core into any rehabilitation program that we do because it is tied to preventing a number of different types of injuries. So when it comes to evaluating injuries and developing rehabilitation programs, we always want to make sure we look upstream and downstream beyond the injury to see if any of these areas are contributing factors. For example, if we have a knee injury, we want to look upstream to the hip and downstream to the feet to see if these are factors. Otherwise, we may miss something very important, like the person in this picture taking a sip of water is missing. Here's all the references. Thanks for watching.